This lecture is intended for undergraduate students, and today's topic of discussion is myasthenia gravis. Myasthenia gravis is a neuromuscular junction disorder which is characterized by the weakness and fatigability of the skeletal muscles. This weakness and fatigability arise from an antibody-mediated autoimmune attack on the neuromuscular junction. This attack leads to the decreased number of acetylcholine receptors at neuromuscular junction. Although there is enough acetylcholine that is present, but because of blockage of these receptors, there is a decrease in the neuromuscular transmission, which leads to the suboptimal action potential of the muscles, and this suboptimal action potential is unable to produce an effective muscle contraction, which leads to the muscle weakness. This is a typical neuromuscular junction in which we can see that a nerve terminal is arriving and making a synapses with a skeletal muscle. This nerve terminal contains vesicles which are filled with acetylcholine. So when this nerve terminal is depolarized, it releases the acetylcholine into this synaptic cleft. This synaptic cleft contains acetylcholine receptors. These acetylcholine receptors, when bind with acetylcholine, this lead to the opening of voltage-gated sodium channels. This influx of sodium then generates a muscle action potential. What happens in myasthenia gravis is that although the acetylcholine is released, these receptors are blocked by anti-acetylcholine receptor antibodies. These antibodies attach to the active site, so there is no receptor present for acetylcholine to bind, and hence no action potential is generated, or the action potential that is generated is very weak. This weakness and fatigability is the cardinal feature of myasthenia gravis. So, pathophysiology, we have discussed that binding of anti-acetylcholine receptor antibodies to the active site on acetylcholine receptors leads to a decreased action potential. But what happens over a longer period of time is, because of disuse of these acetylcholine receptors, there is a degradation of these receptors which goes on. As a result of degradation, the postsynaptic folds, they become simplified and flattened. This leads to a decreased neuromuscular transmission, and only small end plate potentials are produced. This failure of generation of muscle action potential leads to the weakness, and which is the cardinal feature of myasthenia gravis. So here is a pictorial presentation of a normal neuromuscular junction that we have already seen, and here is a neuromuscular junction of myasthenia gravis patient. We can see that perisynaptic terminus is normal. There are acetylcholine vesicles, but the number of acetylcholine receptors has decreased, and the postsynaptic fold, they have become flattened and simplified. So what causes this autoimmune response? Actually, we don't know exactly what happens, but there is a hypothesis that thymus plays an important role in this autoimmune response because it is abnormal in 75% of patients of myasthenia gravis. Of these 75%, 65% have hyperplastic thymus, while 10% have thymomas. So what causes this autoimmune response is that thymus has muscle-like cells. On muscle-like cells, we have acetylcholine receptors. These acetylcholine receptors act as autoantigen and generate an autoimmune response which attacks the normal acetylcholine receptors of the skeletal muscles. If we talk about the burden of this disease, the prevalence is 1 to 7 per 10,000. It can involve all age groups, but its presentation is usually early in female during their 20 to 30s and men in their 40s to 60s. It has a predilection for female, and female to male ratio is 3 to 2. The main clinical feature of this disease, as you might have guessed from our previous discussion, is weakness and fatigability. The weakness, which is characterized by worsening on repetitive use and improvement on rest. So there is a weakness of muscle that get worse when it is used, and these muscles become strong again when they are rested. So that's why there is diurnal variation in this disease. The patients usually feel weak at the end of the day. This is an example of weakness that is produced in myasthenia gravis, and one of the classical presentation of myasthenia, that's ptosis. The characteristic pattern of this disease is that initially it involves eyelids and extraocular muscle initially, which manifests itself in the form of ptosis and diplopia. Then progressively it involves facial muscles, which results in difficulty in chewing, and then bulbar weakness, which results in nasal regurgitation of food and liquids and nasal voice. In the later stages of this disease, causes a weakness of diaphragmatic muscles, which leads to the respiratory weakness and failure, and patient goes into myasthenia crisis. This is manifested as shortness of breath and decreased breath holding time. So if a patient presents to you with the features suggestive of myasthenia gravis, if a patient presents to you with the features suggestive of myasthenia gravis, so there are some screening tests that can be used to assess myasthenia gravis. One of the most common used tests is upward gaze test. The principle is same, that on repetitive use the muscle is fatigued. So you ask a patient to hold his gaze upward for a certain period of time, or usually ask him to count backwards from 50. And as the patient continues, weakness starts to appear in his voice. He is unable to pronounce the words and ptosis develops. The other test that can be done is forward arm abduction. Here is an example of upward gaze test. At time 0, patient has no weakness. But 10 seconds upward gaze, the fatigability of the eyelid muscle has started. And the patient has developed ptosis, which has worsened at 30 seconds. So turning back to the classical pattern of myasthenia gravis, that on repetitive use the muscle is fatigued, and on rest the muscle improves. So here, repetitive use, the muscle is fatigued, and when she rested for 10 seconds, ptosis has disappeared. Now you have done screening and you suspect that patient is having myasthenia gravis. You want to confirm your diagnosis and you want to run some lab investigations. So the test is antibodies to acetylcholinesterase. These are positive in 85% of the patients. If you find these antibodies, this is diagnostic of myasthenia gravis. But if these antibodies are absent, this does not mean that myasthenia gravis is ruled out. Then you need to do other tests like antibodies to MuSK. These are positive in up to 40% of patients who has negative acetylcholinesterase antibodies. Another very interesting test is nerve conduction study or EMG. The principle of this testing is same. We stimulate a nerve repetitively and then we check for the response of the muscles. With repetitive use, the muscle starts to fatigue and the muscle response diminishes with time. This is called decremental response. This is an example of decremental response on nerve conduction studies. We can see that in healthy individual, the response is seen on repetitive stimulation. But in myasthenia patient, the muscles have started to fatigue, and as a result, the response has decreased. This is called decremental response. Tensilon test. This is another test which should be performed with great precaution, because in this test a drug called adrophonium is injected. This drug can cause syncope and bradycardia. So before performing this test, it is obligatory to get an ECG of the patient to rule out any underlying cardiac disease and have atropine in hand in case it is needed. So how this test is performed? In this test, before test is noted, or you can take a picture and then you inject an initial dose of 2 mg of adrophonium. If there is definitive improvement, you can stop here. The test is positive, and if improvement does not occur, you can proceed and give the remaining 8 mg of adrophonium. Look here, this gentleman has complete ptosis before the adrophonium administration. But once adrophonium is administered, the ptosis has disappeared. So this is a positive Tensilon test. One of the most important differential diagnoses of myasthenia gravis is Lambert-Eaton myasthenic syndrome. Clinically, we can differentiate from myasthenia gravis is that on repetitive use, there is weakness of the muscles in myasthenia gravis, while in Lambert-Eaton syndrome, the muscle strength increases after repetitive use. This is called incremental response. There are other features that can help us distinguish, like this is a perisynaptic disorder and it affects mostly the proximal muscles of lower limb. Along with proximal weakness, there are autonomic features that are present. This disease is basically because of antibodies against calcium channels at perisynaptic membrane, and it has association with underlying lung malignancy. The treatment of this condition is plasmapheresis and immunosuppression. Another important differential is botulism. Botulism is caused by a toxin which is produced by Clostridium botulism. This is a foodborne bacteria. In this disease mainly manifests as weakness of bulbar muscles, and autonomic features are also present. This condition can be diagnosed by toxin in serum and reduce compound muscle action potentials. Treatment is by antitoxin. As you might have learned previously, that if there is one autoimmune condition, other autoimmune conditions are associated with this and can be present. The most common of which is hyperthyroidism, which is associated with Myasthenia gravis. So whenever you see a patient of Myasthenia gravis, please do thyroid function test. There are different treatment options available which can be used according to the condition of the patient. But the mainstay of the treatment is anticholinesterase medication. Then there are immunosuppressive agents, thymectomy, plasmapheresis, and intravenous immunoglobulins. We will discuss these one by one. Anticholinesterase medication. So we remember from our previous discussion that Myasthenia gravis is because of blockage of acetylcholine receptor. Although the acetylcholine is present, but it cannot bind to the acetylcholine receptors because of the blockage. So what happens to this acetylcholine? Actually, this acetylcholine is degraded rapidly by cholinesterase enzyme. So what is the mechanism of anticholinesterase drug? That it blocks this enzyme and blocks the degradation of acetylcholine. So acetylcholine is present in more quantity and for longer period of time for these receptors. So there is a greater chance that acetylcholine can bind these receptors and improve the weakness. The drug that is most commonly used is pyridostigmine. It has a short half-life of 3 to 4 hours. The usual dose is 30 to 60 mg TID, and maximum dose of 120 mg 3 to 6 hours daytime can be given. The main side effects are abdominal cramps, salivation, and diarrhea. Immunosuppression is another option, as we have learned from our discussion that this is an autoimmune antibody mediated disease. So if we can block the immune response, we can suppress this disease. So these are the drugs that are used for the immunosuppressions, like glucocorticoids, cyclosporin, tacrolimus, mycophenolate, mofetil. You have given these drugs, but patient is not going into remission. Patient is refractory to treatment. So high dose cyclophosphamide can be administered to reboot the immune system. There are the options that are used in myasthenia crisis, like intravenous immunoglobulins and plasmapheresis. Thymectomy. This is an interesting option because we have learned from previous discussion that in up to 75% of patients, thymus gland is abnormal. So removing of this thymus is an option. Up to 85% of patients, they improve clinically after thymectomy, while 35% achieve complete remission. But the negative point is that the improvement is delayed. It's not like that you have done thymectomy and patient is cured. It will take longer period of time for the patient to go into remission if there is any, or improvement if there is any. So all those patients who have generalized myasthenia gravis and are adult, less than 55 years of age, and appropriate facilities are available, can be considered for thymectomy. Those patients who are younger than 15 years or have localized myasthenia gravis are not considered candidate. One very important point, that those patients who are anti-MuSK antibodies positive, they do not respond to thymectomy. Cholinergic crisis is a very important complication of the treatment. As we have discussed that we give anticholinesterase drugs. These anticholinesterase drugs, they increase the availability of acetylcholine. If these drugs are given in higher doses, then acetylcholine is available in higher quantity. This leads to cholinergic crisis. These have symptoms similar to organophosphate poisoning, and the treatment is atropine. One important complication of this disease, cholinergic crisis, is a complication of treatment. Myasthenia crisis is a complication of disease. A patient is stable, and if there is stress in his life, like he has gotten an infection or he has gotten a surgery, his need for acetylcholine increases. So if the drugs or the treatment is not improvised accordingly, there will be shortage of acetylcholine, and which will lead to the myasthenia crisis in the form of weakness of respiratory muscle, and the patient will usually present with shortness of breath and difficulty breathing. The treatment is intravenous immunoglobulins and plasmapheresis, and this patient should be managed in intensive care unit. This is probably the most important slide for undergraduate students, that you need to remember these medicines by heart that are to be avoided in myasthenia gravis. These include antibiotics like ciprofloxacin, levofloxacin, azithromycin, erythromycin, streptomycin, then local anesthetic like xylocaine, beta blockers like propranolol, atenolol, muscle relaxants, and other drugs like quinine, magnesium, and penicillamine. To summarize, myasthenia gravis is a neuromuscular junction disorder which manifests itself in the form of weakness and fatigability. This weakness and fatigability is because of delayed or suboptimal neuromuscular transmission, which is produced by the blockage of neuromuscular junction by anti-acetylcholine receptor antibodies. Thymus is hypothesized to be involved in this process. Anti-acetylcholine receptor antibodies, if positive, confirm the diagnosis, and the patient usually presents with the features of fatigability and weakness that is worse at the end of the day. And the treatment option is anticholinesterase drugs, immunosuppression, and thymectomy. Thank you.